Actually, plug into here. See that? Okay. This one may not, but the next one does have sound. So let's start with this guy again, then we'll go back to him. This one may not have sound. Okay, so remember he had a masked face, he's got a tongue tremor. See, he's got a little drool on his lips. He's got some troubles with vertical gaze. Relatively young man. Slow horizontal eye movements. But his major complaint was what you'll see in his upper limbs. Again, difficulty with up gaze. But this was his most disabling symptom, a postural and action tremor that really interfered a great deal with his day-to-day function. Okay, so let's move on. And this is his history. 39 years old. At 19, he had cognitive difficulties and had to stop school. He became slow in his early 20s or mid-20s, developed depression, was on SSRIs, and was treated with levodopa for what, as you saw, was his Parkinsonism, but his major disability was his tremor. Now here's another man.
Yeah. Now try not to move
with the same disorder.
The ceiling. Okay. And now look at the camera.
Again, a masked face, significant difficulty with vertical gaze.
Okay, good. Look at the camera. Look over at your mom.
Difficulty looking horizontally now.
Over at me.
Head thrust to generate a horizontal eye movement.
Now try not to move your head. And look at your mom again. Good. And look at me.
So that's helpful.
Look at me. Pointer. And follow the pointer.
Whereas his pursuit eye movements are better. So second, even superior, vertical and horizontal.
Follow. Go. Down. Very good. Close your eyes and keep them closed. Now open them quick. Now close them. And open them quick. Good.
Some slowing of his eyelid opening. Difficulty with lower facial movement. I'm asking him to smile. Just not moving his lower face.
Can you put your tongue out?
Very important sign.
Try to keep it out.
Difficulty protruding his tongue, and when he gets, he can't keep it out. But like the other patient I showed you, one of his most disabling symptoms was a postural action tremor.
Like this. Good. Okay, excellent. Just rest your hands down. So the shaking doesn't occur when the hands are resting.
Really nothing at rest. Now it's not just tremor, you see some posturing in his hands as
Hold
well.
hands like this.
But here's where it starts to cause problems with posture and particularly action.
And then touch your nose.
To the point that it would cause him to spill things, drop things.
Can you do it with the other side?
So these are two young men with more than just posture and action tremor, but postural and action tremor are the major sources of their disability. And that might make you not think of the correct diagnosis. But there were other clues here on the examination, particularly in this case, the difficulty he had with orolingual movement, difficulty protruding the tongue, the eye movement abnormalities. Both of these individuals have a dominant family history, and in fact, this is postural and action tremor as a major manifestation of Huntington's disease. And most people think Huntington's disease is a cause for disabling tremor. Most of the patients with Huntington's and tremor have what's called the Westphal or Westphal variant, which is the akinetic rigid or Parkinsonian variant. And you saw that both of them had features of Parkinsonism. This I'll just show you out of, just to tell you that you might not think of this. This is a 19-year-old man who had clicking in his ears bilaterally for some time. Began at the age of 7. It became bothersome, variable frequency. It resolved when he sleeps, so if was getting dozy and drowsy, it would go away. He denied any control over the symptoms, and he was particularly bothered by the clicking sound. He had an interesting past history of inner ear infections. And so he had tympanic membrane atelectasis and had multiple operations for cholesteatoma and tubes. He had been treated with various medications. He's got a family history that's unimportant and a normal MRI scan. And what we did, and I'm going to show you, we taught him something. So when patients come to you with clicks, do you know what you think about? Click, 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 and you can actually hear it in the room. That is often referred to as isolated palatal tremor, or the term that I don't like is called essential palatal tremor. And this is typically due to the soft palate rhythmically moving, and it's the tensor veli palatini muscle, the anterior soft palate, that's moving. And in fact, the vast majority of people with essential or pure palatal tremor have a functional or psychogenic cause. You wouldn't think that, but the majority of them have a psychogenic cause, but some people can learn to do this. Wind instrument players, divers, can learn to move their palate to clear their eustachian tube. And so this young man, probably because of the infections, had developed this as a habit. And we taught him that he could control the palatal movement, and this is him after he's learned to control it.
Okay, now do the clicking.
Now we're allowing him to do it.
Let it go.
And he's actually learned that he can do it at multiple speeds.
Okay, now, can you speed it up? Okay.
So normally you would think this has got to be due to a brain disease. And when the levator veli palatini is involved, it is. That is secondary palatal tremor. It's usually due to a lesion in the central tegmental tract.
3, 4, 5.
The inferior olive, the contralateral on the side of the lesion usually is hypertrophic. You see this on MRI scan, usually flared. But this young man has actually probably learned to do this because of his inner ear infections. They didn't know that he was doing it at all. Now this, let's skip this guy, he's interesting too. He had clippers. I'm going to skip this. Oh, this is an interesting lady, just to show you, probably read about this in the literature. This is a woman with corticobasal degeneration, and she manifests as alien limb. She doesn't want to do this. Her hand keeps coming to her face and wiping her face with the Kleenex.
Is that like when your hand would come up to your face and take your glasses off?
And early in the disease, her hand would come up and remove her eyeglasses, or go into her purse and grab things in her purse when she didn't want to do that.
You're trying to prevent that hand from doing that. Don't let it do
She
it.
doesn't want to do this. She's trying to stop it, but the hand keeps coming to the face.
Okay. Very good.
This is actually an uncommon manifestation of corticobasal degeneration. In fact, Alzheimer's disease causing corticobasal syndrome. We now talk about corticobasal syndrome with the pathology of corticobasal degeneration. It's a tauopathy like PSP as one form. And actually, alien limb is less common. What does this lady have? Think movement disorder first. What's the phenomenology?
Keep it up.
Faster to protruder tongue. Keeps popping in. So think phenomenology, think distribution. Look at her eyes, too. So is this tremor? No. Is this dystonia? No, it's more mobile. It's chorea, and in fact, look at her eyes. Her eyes are involved too. The movements are so large amplitude that these are really ballistic movements. Wild flinging proximal movements are balism. So we talk of chorea balism on a spectrum. Chorea is usually the more distal parts of the body. Larger amplitude proximal joints are ballistic usually. So this woman has bibalism, bilateral ballistic movements. I was called by the referring neurologist and he said, I've got this young woman with severe abnormal movements and I don't know what's the cause. And I say, has she been healthy? Yeah, as far as I know, she's been healthy. Tell me about her pregnancies. Oh, she's had 5 spontaneous abortions, miscarriages. 5. What do you think? Anticardiolipin antibodies due to systemic lupus erythematosus. So this young woman, her first manifestation of SLE was bilateral balism due to anticardiolipin antibody syndrome. And she actually responded very well to treatment. Everything settled down. In fact, this was, you see this in old videotape. I've seen her recently with a very mild recurrence of chorea on one side. Many years later, now about 20 years later. And these patients can do extremely well if you treat them properly. Very important syndrome to like. Okay, listen to her voice now.
Yeah.
And I was flying through the door.
Yeah.
Now,
And
let's
in the
pause.
reception hall, I picked.
This woman had been seen by another movement disorder neurologist, and he said she had stuttering. Voice stuttering. Now, listen to her voice, and I want you to tell me, is this stuttering or is this something else? You'll also know she's got tremor. And in fact, I'll tell you now, she has Parkinson's disease. Now, some people with Parkinson's, with a past history of stuttering as a child, will manifest stuttering again as their Parkinsonism develops. So stuttering in Parkinson's can occur. But listen to her voice and tell me if you think it's stuttering.
And I was flying through the door.
Yeah.
And into the reception hall. I picked up a glass of wine.
Yeah.
And it didn't go. 3 or 4 steps.
Yeah.
It's more irregular.
I didn't spill the wine.
And was it your typical Parkinson's tremor that you developed?
No.
Like you have now, or was it different? So
She says, it's not like my hand tremor. This is different than my hand tremor.
No. Well, what's different?
What's the phenomenology? These are jerks, myoclonus, right. And this is action myoclonus of the face and voice. Very specific. You see this in somebody with Parkinson's disease, you say amantadine. And indeed, this woman was put on amantadine, and we've seen several patients with this very characteristic oral, lingual, mandibular, action-induced myoclonus. You stop the amantadine, it goes away. They often have additional jerks, and I don't know whether you noticed, she had little action jerks of her axial musculature as well. This is the man that I saw in the hospital.
Now tell me what bothers you the most.
Again, phenomenology first.
Yeah. Have you bitten on the tongue? Did you bite it? No? Now it's a Have you had trouble?
The movements are only in this part of the face in him, but they may be generalized. If anything, they lessen when he's concentrating on writing.
And then touch the tip of your nose. Back and forth.
He's got a little action tremor too.
Okay, now the other side.
I think he had some shoulder
Good. Can you
joint
do this for
problems.
me now?
He couldn't lift the shoulder, but that's musculoskeletal, different.
Okay, the other side?
No Parkinsonism.
Like that. Tap the thumb. To the
And you see the facial movements may get a little worse when he does this, but not striking.
And the other side? No, open, close like that.
Okay, so before we do that, I'm going to pause. So what is the movement disorder? It's repetitive, non-rhythmic, flowing movement of his face, eyes, lip. So it's not really dystonic. He's not got prolonged blepharospasm, but he certainly had eyelid involvement. It's more a choreic movement, and some of this would make you think of tardive dyskinesia, right? Orolingual tardive dyskinesia. And so, in fact, if you saw this man, the first thing you should think of is drugs. Tardive drug-induced dyskinesia due to antipsychotic drugs, metoclopramide. That would be very reasonable to think about. Okay? Now, remember, 3 months later, something has happened to him.
Now, open and close your right hand.
He's still got a
Nothing
little
to do with
bit, not
the left.
much.
Now, unscrew the light bulb.
But much
On
better,
the other
right?
side. And
Okay. So, a couple points about tardive dyskinesia. Orofacial lingual dyskinesia, often much worse when patients perform activities in their limbs. So, if you think you've got somebody on neuroleptics that you're examining and you think you might be dealing with a little bit of orolingual dyskinesia, have them open their mouth and perform a rapid alternating movement. And you'll often see the tongue start to wiggle or protrude. That's a very early manifestation of tardive dyskinesia. In fact, you saw a little bit of that here, but not that much. In fact, sometimes you wondered whether it dampened down when he was writing. What happened between the first video and the second video? He was treated. If he had tardive dyskinesia, we could have used tetrabenazine or another neuroleptic drug. Usually it's not just stopping the neuroleptics. If you have somebody with orofacial dyskinesia due to a neuroleptic, you stop the drug, often they will get much worse to begin with. They get a withdrawal dyskinesia or worsening, and then over weeks to months, it may take time for them to get better. So that's more typical of tardive dyskinesia. This man was treated with lactulose. Why? He had had symptoms for 2 weeks, the orofacial movements, but also had episodes of confusion. No history of exposure to antipsychotics or dental procedures, but he had cirrhosis. Hepatic cirrhosis, hepatitis C positive, you see the liver function studies, CT of an abdomen showed liver cirrhosis. This is a patient with acquired hepatolenticular degeneration. And acquired hepatolenticular degeneration is a complication of cirrhosis, but also shunts. So you can get congenital liver vascular abnormalities with hepatosplenic shunts. So you don't have to have liver disease, but this is much more common with cirrhosis. And in fact, big liver centers, if you have a big liver center in the city, they are seeing these patients. This is not that uncommon a problem, so you should be aware. And the first patient I saw with this had quite severe generalized chorea, and they often have a lot of orolingual involvement. And the clue is the episodic worsening when they get more encephalopathy. So the movement disorder is often much worse with encephalopathy. You treat the encephalopathy, lactulose in this case, and the patient improved. Okay, this is a 68-year-old man who in 2011 came to me for shaking in his legs. Left side was worse, and he noticed that there were triggers that worsened or brought it out. Trying to put his shoes on or touching the sheets with the foot would cause, or walking barefoot, descending the stairs or lifting the foot to get out of the car would often make the movements much, much worse, and this would sometimes cause him to fall. So again, figure out what the movement is.
In the air, hold it up. Now put your heel on your knee. Put the heel on that knee and just hold it in position. Tap it up and down. And now slide it straight down the shin.
Little bit of irregularity, or not too bad.
And now touch the pointer, or touch the reflex hammer with the big toe. Okay. Put the heel to 7. Okay. Same thing. Heel on this side to the knee of the other.
Remember, the left side is the one that's most involved. He's having a lot of difficulty moving.
Bring it down, shin.
Now you might be tempted to say that's ataxic, but it's actually not.
Okay? And lift the foot.
It's jerking.
Lift the foot up and touch the.
And it's jerking when he's attempting to make the movement. And you'll see it jerks in response to
Got
what
it on the shin. Is that painful?
It's not painful, it's just
The sudden jolts that do it, but it's the jolts are not painful.
no, it's not painful.
Okay. Back down, heel to knee, and just do it once more. And slide it down.
So I'm touching his feet, left, right side, not much. And if you don't get anything the first time, keep trying. Keep touching various different parts of the limb.